didn't actually understand. They didn't actually understand the principle of the basic airway adjuncts, and we stopped there. So today our aim is to round up with the principles of resuscitation, so that we can move on with other things as from tomorrow. So we'll just briefly repeat this basic airway adjuncts to make it clearer for some of you guys. So what we are talking about yesterday is the fact that we have two basic airway adjuncts. Yesterday we were able to clarify that in any patient with airway compromise, that the first intervention we want to do after. Yes. Hello guys. Hello guys. Meet your system. Hello guys, please mute your system. Mute your system so that we can be able to hear each other. Thank you. So yesterday we were talking about the how to manage a compromised airway. So we said that the first principle is to establish that the airway is compromised. After it is established that the airway is compromised, then we'll move ahead to manage the airway, to open up the airway. And we were able to list those signs that will tell us that this airway is compromised. So after those signs are established, after we're able to pick those signs that this airway is compromised, a patient in difficulty in breathing, an unconscious patient with also difficulty in breathing, or a patient whose chest is not rising as expected, a patient that is breathing, but the patient's breathing is noisy or wheezy. So all of these things are telling us that this patient's airway is not patent. So we want to manage that airway, to open up the airway. And we said that the first thing we need to do whenever we suspect that the airway is not patent is to do the head tilt and chin lift. So we're going to do the head tilt and chin lift, and we're able to show the picture on how it's going to be done. It's a very simple maneuver that we'll just do, to open up the airway and look through the airway. And we said that after doing the head tilt and chin lift, the next thing that we're expected to do is to check through the airway to see if there are secretions. So if there are secretions, we try to suction the airway in order to open it up. So if we also look through the airway, through the mouth, through the nose, if we're able to see any foreign body, maybe a food particle or any foreign body, especially in children, they can pick up an object and put it through the nose, and the object can dislodge from the nose and obstruct the airway. So if we look through and we're able to see any of this foreign body, the next thing we need to do is to use a forceps and try to pull out the foreign body out. So suctioning and using a forceps, to salvage the airway are the first line intervention, that the first thing to do in any airway that is compromised. And we're able to move on to say that if these two interventions, suctioning the patient, or if there is a foreign body, trying to pull out the foreign body, if they are not able to salvage the airway, to open up the airway, then we need to go further to put up a basic airway adjunct. And we said that the indication for basic airway adjunct, he said any patient with floppy, what we call floppy, or soft pharyngeal muscles, or any patient that is unconscious and the tongue is kind of dislodging backward, or in the case of respiratory tract infection, where we have edema, swelling of the pharynx, obstructing the airway. So these are the additional indication for basic airway adjuncts. And as of yesterday, we're able to say that there are two of them of basic airway adjuncts. We said we have the oropharyngeal airway and we have the nasopharyngeal airway. We're able to show the picture of both of them. And we're able to establish the difference between the oropharyngeal airway and the nasopharyngeal airway. We said that the oropharyngeal airway, patient who is not conscious, A patient whose gag reflex, and we have to establish what a gag reflex is. A gag reflex is so that choking sensation, that somebody is choking, somebody is about to vomit. That sensation is what we call gag, G-A-G, gag reflex. So oropharyngeal airway is used when in a patient that is unconscious, whose gag reflex is not intact. So if we put it through the mouth, it will not induce choking. It will not induce vomiting for that patient. So that is when we use oropharyngeal airway. However, nasopharyngeal airway can be used both in somebody who is conscious and somebody who is not conscious, both of them, because it's not going to stimulate a gag reflex. It's not going to make the person to start coughing, to start vomiting, to start choking. So that is the difference between the oropharyngeal airway and the nasopharyngeal airway. So we're able to say that the oropharyngeal airway has a J-shaped, it's a J-shaped plastic device that can fit in the mouth, and it tend to kind of press the tongue down in order to prevent it from falling backward, and helps to open up the airway. Like I've said before, it should not be used for any patient who is conscious or semi-conscious, because it's going to stimulate gagging, vomiting, and the patient must actually aspirate, and that is what one of the things we actually don't want. So this is the main contraindication said oropharyngeal airway should not be used in a conscious or semi-conscious individual because it can stimulate gagging, vomiting, and possible aspiration. So we're able to establish this picture, the picture of the oropharyngeal airway. We're able to establish it. We said it is curved, and it's not as round as the nasopharyngeal airway. The nasopharyngeal airway is round, just as the nose is round, and the oropharyngeal airway is not round. It has the shape of the mouth. As we can see, the mouth is not round, but the nose is round. So the nasopharyngeal airway is round, smooth and round, but this one has the shape of the mouth. The oropharyngeal airway has the shape of the mouth. Nasopharyngeal airway has the shape of the nose. It is round. So we'll talk about the how to insert the oropharyngeal airway. So as a paramedic to you are the assistant at the emergency unit and the first person in contact. So as soon as you check this patient, the airway is compromised, the next thing you need to do is do the head teeth and chin lift. As soon as you do that and you're able to see that this patient is having secretion all over in the mouth, and suction the patient. You suction the patient, you check the SpO2, it's not satisfactory, then you can go ahead and insert any of these. If the patient is conscious, go ahead and put nasopharyngeal airway. If the patient is unconscious, deeply unconscious, go ahead and put oropharyngeal airway. So how do we do this as a paramedic personnel? The first thing you need to do is to clear the mouth of blood and secretion. So you suction, which is the first thing we have said. You suction the patient to remove all of those secretion from the mouth and from the nose. So after you have suctioned the patient, you need to look for the size of the oropharyngeal airway that is that of the patient. And we're able to talk yesterday, to establish yesterday on how we can know which of these will size the patient. We said to know the one that will size the patient, we are going to measure it. We put the device from the angle of the mouth to the earlobe. We'll place the device. We are going to see the picture subsequently. We'll place the device from the angle of the mouth to the earlobe. So anyone that the size will extend from that angle of the mouth to the earlobe will definitely, or is likely to be the size of the patient. So how do we insert it? We'll use the cuff end, the tip, the cuff end, we'll put it into the mouth of the patient, and we'll make that cuff end to be looking towards the roof of the mouth as if it's facing the brain. So when we put it like that, and when we put it like that, and the length is almost inside, the length of the device is almost inside, then we can now do anti-clockwise rotation. That is, we'll just turn it towards the left-hand side in order to make the device to fit in. So this is just the picture. So this cuff end, the cuff end of the device will enter facing the roof of the mouth, as if it's just facing the brain. So we insert it, go deeply like that. And when we get to this point, we'll go, as this person is holding this device, at the upper end, we'll see where it has another little curve. At that point in time, when we get to the point where there is a little curve up there, then we can now do the anti-clockwise pharyngeal airway perfectly. So this is what I'm talking about. So if we look at this device, it's as if we have gone about 1/3 of the length of the device when we get to that curve at the upper side. So when we get to that curve, we now do anti-clockwise rotation in order to fit in the airway perfectly. So that's how we insert it. So let's recap the step again. The first step is to suction the patient, make sure there are no secretions, no blood, no fluid, the air is clear. The next thing we are going to do is to measure. When we measure from the mouth to the earlobe, it's likely going to size the patient. What we're going to do is we insert the oropharyngeal airway with the tip facing the roof of the mouth. We gradually put it in. So when it gets in about 1/3 of the length, where we have a curve at the upper side, we'll now do anti-clockwise rotation. Rotate it as if we're rotating it towards the left-hand side, and then gradually push the remaining in to fit in the mouth. So that is how we insert the oropharyngeal airway. So you will do the practical aspect of it at the hospital. So nasopharyngeal airway, as we have established before, that the nasopharyngeal airway can actually be used in a patient who is conscious and a patient who is not conscious. So if any patient is coming with airway compromise, you have suctioned the patient and the patient is still having some difficulty in breathing, the airway is not relieved, the patient is conscious. What you need to put is nasopharyngeal airway, not oropharyngeal airway. Because if you try to put in the oropharyngeal airway, you will induce vomiting and gagging. And gagging is like coughing. The person will start coughing. So you induce that. So you don't want to induce that. So you go ahead and put nasopharyngeal airway, naso, the nose. Okay, so it's a plastic rubber we have seen before. As I explained before, it's more round. You just have the shape of the nose. So the difference in terms of insertion, of the nasopharyngeal airway, the difference between inserting the nasopharyngeal airway and the oropharyngeal airway is that in oropharyngeal airway, we do not need a lubricant. We do not need to lubricate the device. But in the nasopharyngeal airway, we will need to lubricate the device. Some of you guys that have seen where a nasogastric tube is being passed before, you will also notice that we will need to lubricate the nasogastric tube. So anything that goes to the nose is usually lubricated So the nasopharyngeal airway will need to be lubricated. So we lubricate that with a water soluble lubricant. An example of water soluble lubricant is KY gel, a KY jelly, which you commonly see it in the hospital, health specialist hospital. You see KY jelly. So it's an example of water soluble lubricant. So you can use KY jelly, just rub it on the nasopharyngeal airway device, and then you now try to insert it. So like what I've said before, this is just the picture. It's round, but the other one we saw before has a J shape. It's not round. The oropharyngeal airway device. So we just need more caution that if we put an oropharyngeal airway that is too large or too small, it might obstruct the airway. So we should be careful to use the appropriate size. So we must always measure. Measuring is part of the step of inserting any of those basic airway adjuncts or basic airway device. So again, nasopharyngeal airway that is not that the size is not correct, and a nasopharyngeal airway that the size is small can actually enter into the esophagus. So if we use a smaller size and put it through the nose, it will pass through the nose and then dislodge into the esophagus. And that will be a huge issue because the patient will might have to do endoscopy to bring it out. So another precaution is that after we have inserted this, we must make sure the patient is having a spontaneous respiration. So just like the oropharyngeal airway, for nasopharyngeal airway, how do we insert it? Okay, again, the first step is still to clear the airway, suction the airway, make sure there are no secretions in the airway, both the mouth and the nose. So after we have suction, the next step is to measure the size. We measure the size from the nose to the earlobe. Remember, we're inserting it through the nose, so we measure from the nose to the earlobe. So after that, what do we need to do? We have to lubricate the airway. We will lubricate the airway. We lubricate the nasopharyngeal airway device, as we have mentioned before. So we lubricate the nasopharyngeal airway device. So after we have lubricated the nasopharyngeal airway device with a water-soluble lubricant, as we have mentioned before, so we insert the device slowly and we insert it straightly into the face. Remember that the other one, we said we'll insert it with the cuff end facing the brain. But in the nasopharyngeal airway, we don't insert it with the cuff end facing the brain. No, we don't insert it. We insert it straight through the face. And it should be a smooth process. So we shouldn't apply too much force. When we lubricate it and we go in, the device should be able to move in smoothly without putting in any force of any kind. So if we lubricate it and we put it in, it should be able to go in smoothly. And also, just like a nasogastric tube, if we try one nose and we're encountering some obstruction or difficulty, we simply need to remove the device, make sure it has adequate lubricant, and we try the other nose. So it is not compulsory that it must go through in one nose. If we try one nose and we're encountering an obstruction, we remove it and we try the second nose. So we can see smoothly how this thing is being inserted. The tip end is not facing the brain. The tip end is facing is already bent, facing downward. It's bent, facing downward. It's not facing the brain. So unlike the oropharyngeal airway device, and when fitted, when it is inserted very well, this is what it looks like in this picture here. So again, let's recap. How do we insert the nasopharyngeal airway device? How do we insert it? We said the first step is to clear the airway, suction the patient, suction the nose, suction the mouth. And the second step for nasopharyngeal airway device is to measure the length. So we measure the length from the nose to the earlobe. After we have measured the length from the nose to the earlobe, the third step is to lubricate. We use a water-soluble lubricant to lubricate the nasopharyngeal airway device. So after lubrication, we'll now insert it gradually with the curve end, with this curve end facing downward, and gradually insert it into the airway. Simple procedure. First step, suction. Second step, measure the length from earlobe, from the nose to the earlobe. Third step, lubricate the device. And the fourth step, gradually insert it through the nose with this curve end facing downward. Simple and easy to do. All right, management. Airway devices or adjuncts procedure are beyond the scope of your lectures. The device and basic airway management, both the theory aspect of it and the practical aspect of it, how to insert this airway, how to manage them. Then sometime in the future, as you progress in your career, you can now acquire skills on the advanced airway devices and how to insert them, the procedures. So there are four advanced airway devices or adjuncts commonly used, the most commonly inserted. Indications are unconscious patients that are in coma, that cannot breathe on their own. We need to put them on incubator. Don't worry about all of them. So we need to put them on a machine to help in their respiration. That's when we use the endotracheal tube. The second one is what we call a laryngeal mask airway. So that one has a mask underneath it, at the end of it, that can be inflected. And we have laryngeal tube. Then we have the esophageal tracheal tube that we have. And here we just have the picture of endotracheal tube. That is what it looks like. So why it is here is for you to maybe anytime in the future or somewhere you go to hospital, what is it useful? So this is it, is the endotracheal tube. So when it's inserted, this is what it just look like. So from here, the person is connected to. So what we have here is the laryngeal mask airway. The laryngeal mask airway is what we have in here. It has a mask at the end of it. Now a mask look like a face mask at the end of it. So that is the laryngeal airway mask of your lecture today. When inserted, that is what it look like when inserted. So what we have in here is laryngeal tube. When laryngeal tube is inserted, it also the laryngeal tube airway when it is inserted, what it looks like. That is what we have on the right hand side. On the left hand side, we have the esophageal tube. So the difference is that this is that the esophageal tube has two tubes, and the two different tubes, one will connect to the esophagus and the other one will connect to trachea. But all these things are beyond the scope of your lecture today. So those are the airway management, how we manage the airway. It's simple and straightforward. Remember, the first thing you need to know is to establish if this airway is patent or not patent. How do you do that? We said right from the beginning that if the patient can speak, forget it. We assume the airway is patent. Any person that can actually speak, that person's airway is patent. But if the person cannot speak, the person is unconscious, the person is having noisy breathing, the person is in severe respiratory distress, the person's chest wall is not adequately moving when breathing. We say all these things are signs of airway compromise, that the airway is not patent. And we said that if the airway is not patent, we have established that the airway is not patent. What do we need to do? The first thing we need to do is to do the maneuver. Hmm? Is to do the maneuver, the head tilt and the chin lift. We do the maneuver, head tilt, chin lift, look through the mouth, look through the nose. There are secretions, we suction. Most of the time, if we suction the secretions, then the problem is solved. We don't need to go any further. We also look through the mouth, look through the nose. If we see a foreign body, we use our forceps and pull the foreign body out. So pull the foreign body out. But if we do these two things, or we didn't see foreign body, we saw secretions, and we suction the secretions, and the patient is still not better, then we can now move on to the basic airway adjuncts or basic airway devices, which I've just spoken about their indications and how to insert them. So at this point in time, I want to know if there's any questions before we move on to the breathing and other part of the class. If there are questions, please indicate. Please indicate if there are questions. You can type in the chat box so that we can know if there are questions we'll answer before we move on to the next thing. No, okay, fine. No question, we'll move on. We'll move on to the next class. Okay, so having talked about the airway, how to identify airway compromise and how to open up the airway. The next thing we talk about is breathing. I told you guys that the airway management are the most extensive part of this class. So what do we do in breathing? Well, as we are doing airway management, we are also at the same time working on the breathing as well. So both things are done simultaneously. So what do we need to do in breathing? We have to count the respiratory rate as fast as possible because we want to know what is this person respiratory rate? Respiratory rate might be 30, might be 35. We need to know how severe is this respiratory difficulty, noisy breathing. In some other people, don't forget that some other people must be gasping. What is gasping? Those that are gasping are almost dying. They are gasping for air. They are hunger for air. So sometimes you see them, they will breathe once and they will stay like maybe 1 minute, 1 minute before they will breathe again. So in those people, they will have their respiratory rate will be low. So might breathe now. The next thing they will stay like 30 seconds or 10 seconds or 15 seconds or 5 seconds before they will breathe again. So it's not only that the respiratory rate must be high in people that have with respiratory issues or breathing issues. It can be high, it can be low. So for us to know what is the normal respiratory rate for an adult, the normal respiratory rate for an adult is actually from anything between 12 to 18. The respiratory rate of 12 to 18 is considered normal for an adult. However, in patients that are in the hospital, patients that are seriously sick, patients that are ill, critically ill or sick, we still consider the respiratory rate of 22 to still be within a normal range. So in patients that are already on admission in the hospital, critically ill or critically sick, we consider up to respiratory rate of 22. We still consider it as normal. But anything beyond 22 is high respiratory rate, is abnormal. So also in an adult, any respiratory rate that is less than 12 is the respiratory rate is low. So low respiratory rate, bradypnea, high respiratory rate, tachypnea. Those are medical words for high and for low and high. So something respiratory rate that is low is called bradypnea. Bradypnea. Bradypnear. Bradypnea. So respiratory rate that is higher, higher than 22 is known as tachypnea. So in terms of the pediatric age, the respiratory rate actually varies according to the age. Newborn, infants, neonate and infants, their respiratory rate tend to be much more higher. But as they grow up into adolescents, the respiratory rate will now start to decrease as they grow up. Both the respiratory rate and the heart rate in newborn is higher than that of adults. But as they tend to grow towards the adult age, both the respiratory rate and the heart rate will tend to decrease with age. So in them, we won't put much more, won't disturb ourselves more, because the respiratory rate of a child of 1 year will not be the same with respiratory rate of a child of 5 years. So the respiratory rate of a child of 1 year will be higher than the respiratory rate of a child of 5 years. But just know that of the adults from 12 to 18. When patients that are on admission, still 20 to 22 is considered normal. So what we do in breathing, we check respiratory rate very fast, we count it. And the next thing we need to do, if we have not checked before, that's why I say that both the airway and breathing, we do the two things together. So if we have not checked, if I have not checked the SpO2 at this point, so we'll just do it now. Check the SpO2 by connecting pulse oximeter. So pulse oximeter picture was posted in the page, so I believe you guys have seen and know what it is now. We'll connect the pulse oximeter and we're able to read what the SpO2 is. So an SpO2 that is 94 and above is considered normal. An SpO2 that is 94 and above is considered normal. So an SpO2 that is less than 94% is what is considered as hypoxemia. Low oxygen level, hypoxemia, low oxygen level. So any SpO2 that is less than 94%, the person needs to be connected to oxygen. If SpO2 is less than 94, connect the person to oxygen. So the amount of oxygen you are going to give will depend on how low the SpO2 is. If the SpO2 is, let's say, 85 or 88, you know that you will need to give more oxygen in order to bring that SpO2 to equal to or more than 94. Equal to 94 or more than 94, because the target is to make sure that this patient will get at least 94% oxygen saturation. So the amount you are going to give will depend on how low the SpO2 is. So that is actually what we do for breathing. Nothing much. Respiratory rate, put in pulse oximeter, then connect to oxygen if we have not done that. But we usually do it simultaneously with airway management. So after we have managed our airway, what next do we need to do? Is circulation. So what do we do in circulation? Well, the first thing we need to know what is this patient BP, so that we know is the patient in shock. If it's in shock, so that we can intervene very fast. So we need to know what the BP is. So we'll quickly check the BP and check the pulse rate. As long as you check those two things, BP and pulse rate, the next thing we need to do is establish an IV line. So to put an IV line is something you will learn in the hospital, a specialist hospital. You will learn how to insert an IV line. We have different cannulas that we use. We have the blue, we have the gray, we have the pink. Most of the time, it's pink we usually use. You can also use blue. So those cannula has sizes, different sizes that you can use to secure the IV line. So the procedure, you will learn it at the hospital. So as soon as we secure the IV line, the IV access, what do we do? The first thing we need to do is to take sample for basic investigations. So we're going to list those basic investigations when we'll be talking about the general management, initial management. going to be talking about those basic investigations. So when a patient comes to the hospital, accident and emergency unit, there are some investigations that are considered basic. You need to do them for that patient. They are basic investigation, you must do them. After we have taken the sample for these basic investigations, the next thing we are going to do is to put up IV fluid if it is indicated. So that is why we must check the BP, because it's the BP that will tell us whether this person will need IV fluid or not. If the BP is low or very low, we need to put up IV fluid to optimize the BP. So that's why we need to quickly check the BP and pulse rate so that we know if we are going to put up fluid for that person immediately or wait a little bit. So this just a little bit on if this person will need any medication at that point in time. So we just give if there's any medication, like most of the time, as you would see in the health specialist hospital, you also see that sometimes a patient will come and the doctor is still busy and the patient is having high body temperature, a high fever, and you will see our nurses run around. They will need to give paracetamol in order to control that fever before the doctor will come to take detailed history and other things. So those are an example of medication we can give, bolus. So bolus means you give it once, unlike what we call infusion. Infusion will give infusion over 2 hours, 4 hours. That one is infusion. But the one will give bolus over the next 10 to 30 seconds. We call that bolus. So we'll give an example of such is paracetamol for in a patient with high body temperature. So then another thing we want to talk about is the fact that though we don't routinely practicalize it. We expected that any patient we are giving a medication, we need to flush the line with 20 mils of normal saline or Ringersin lactate. Flush the line. So flushing the line with 50 mils will make sure that that medication will circulate all over the body and start working as fast as possible. So flush the line with 20 mils of fluid. So it's also expected that we raise the arm we have given the medication a little bit for about 10 seconds, also to enhance the medication to circulate throughout the body as fast as possible. So here you don't need to bother yourself about this one. It's just another route we can use to administer drug. Intraosseous means administering the drug through the bone. So we use a special device, a drilling machine, which will attach a special intraosseous needle on it, and we just use it to pierce the bone, drill the bone, and we'll put the needle or the cannula inside the bone and use it to administer fluid and medication. But this is used only in a patient whose line is very difficult to secure. Any patient whose line is very difficult to secure. So just know that we can actually give medication and IV fluid through the bone marrow. Okay, so in disability, what we do in disability is also a little bit straightforward though. So in disability, the two important things we need to do in disability, as you know, again, dextrose means sugar, the blood sugar. The blood sugar is what we call it. Either you call it glucose or you call it dextrose. So one of the two important things you need to do in this deep part of it is to quickly check the blood sugar. Remember, most of the patients you might encounter their problem might fall in D, not in A, not in B, not in C, but in D. So you check the airway is patent. You move to B, you check breathing is fine. You move to C, you check C, circulation is fine. So you now come to D, and the D might be where we have the problem. An example of when we have problem at D is hypoglycemia. You have a patient who is a diabetic patient using insulin, and the patient was at home, and she probably didn't eat very well in the morning, and she took her insulin, maybe 10 international units, and injected it to herself. And before you know it, within the next 45 minutes, they tell you, Mama cannot move again. She cannot move again. She cannot talk again. The family will now bring her to the accident and the emergency unit. And you are the first person to attend to this patient. So what you need to do is simple. What we have just talked about. You look the airway. The airway is fine. Mama is breathing. No problem in the airway. You rush through the breathing. The SpO2, you check SpO2 is 96%. You check the BP is fine. You check the pulse rate is also fine. The next thing you need to do is come to D. So you check the dextrose and you are seeing a blood glucose of around 2 millimole per liter. Around 2 millimole per liter, when at least you are supposed to see the normal person, you are supposed to see 4 millimole and above. What is considered hypoglycemia is when the blood glucose is less than 3.8 millimole per liter, 3.88 millimole per liter. So any person that is having 4 and above is less likely the problem. So you check the blood glucose and you are seeing that mama is having 2 millimole per liter of blood glucose. Of course, that is the problem. So the next thing you need to do now is you put up a glucose containing fluid, and within the next 10 to 15 minutes, you see mama will start to talk again. So that is it. So that's one of the things we do in this D aspect of it. We check the blood glucose, we check the temperature of the patient, and then we do what we call, we assess the GCS. The GCS is a little bit complex. I sent the GCS, how to access GCS in the WhatsApp page, but I'm going to go over it. Let me be true with the E. I'm just going to go back and explain it. So we'll do the glucose level, we check the temperature, we check the patient GCS. And why it is important to check GCS is the fact that any patient that has a GCS of less than 8, that patient will consider that patient to be in coma. So if you get a GCS of less than 8, we need to call the ICU people. We call them the ICU people, so that we need to admit that person to intensive care unit. Why do we have to admit the patient to intensive care unit? Because it's assumed that any person that the GCS is less than 8, that person will not be able to breathe on his or her own. So the person will need machine to support in the breathing process. So I'm going to come back and explain a little bit the GCS, what it is all about. So the final part of the resuscitation process is exposure. What is exposure? It's simple. We open up the clothes of the patient. If the patient is putting on clothes, we try to open up the clothes and review. Why do we need to open up the clothes? The exposure part of it is majorly important in people that are coming in with trauma. Maybe somebody that have had an accident on a bike, and the bike has an accident, and they rush the person to accident and emergency unit. Of course, you will need to expose the patient to be able to take note of all the places the person have had wound, injury. If you don't open it, you might miss a massive injury, which might be the one that might be infected in the next 2 days or so, and probably be what will kill that patient. So exposure is important in the case of trauma, people that have had trauma, road traffic accident, gunshot, penetrating wound, and so forth and so on. Then in patient that maybe their family member have also poured water on them when they collapsed, when they fainted, you also need to look at how wet the cloth is, expose them, and also change that cloth, bring a cloth to keep them warm, because you don't want to still keep them on that cloth that is wet with water. So in the exposure as well, we should also remember to insert catheter, especially in patients that are unconscious. I have to insert urinary catheter for them, because they won't be able to get up to go and urinate by themselves. So that forms the end of the resuscitation class. The resuscitation class. So maybe before I move on, I would want to know if there are any questions before I'll explain the GCS for you guys. If there's any question, let me take it before I will explain the GCS, so that I will end the class. Okay, so what the complication if it is not if it if it's not placed well. Okay, so I was saying that those complications, the complications of the basic airway devices, if they are not placed well, the complications I pointed out some of them. If they are not placed well, the most common complication is the fact that instead of opening up the airway, it will obstruct the airway more. It will obstruct the airway more. One of the reasons we want to place those basic airway devices is to open up the airway. So if we don't place them very well, they will obstruct the airway. Remember that they are solid objects. So we must put them in a way that their opening will be patent so that air will pass through them. Please, I have the patient clothes so that air will pass through them. So if they are not placed well, they will obstruct the airway. I also said that if the sizes are small or bigger than the patient size, they will also obstruct the airway. And in the case of nasopharyngeal airway device, if the size is too small, it might dislodge and enter into the esophagus. So remember that the esophagus is the food pipe. The trachea is the windpipe. The esophagus is the food pipe. So it will enter into the food pipe and cause more bigger obstruction. So another thing I forgot to mention in the case of nasopharyngeal airway is the fact that if the patient has trauma, any trauma on the face, you must be careful. We have a lot of accident cases in health specialist hospital. Accident cases will be coming and coming. So in such patients that are accident cases and they have trauma on the face, when you are passing the nasopharyngeal airway, you should be careful um, so that you wouldn't dislodge the nasopharyngeal airway through those wounds. Because you can put it and the thing will go through a bony fracture. And from that bony fracture, it will dislodge and enter into the patient's body. So, and when that happens, you need that it might be a surgery to, where you might have to undergo surgery to pull the airway device out. So, when a patient has a facial trauma, you can put it, but you need to be more careful so that it won't dislodge through fractures. Please, sir, if the patient clothes that is wet is not removed, what will happen? Well, the patient will not feel comfortable and the patient will have low temperature, low body temperature, hypothermia. Patient will have low body temperature, hypothermia, and patient might not be comfortable. So that is why we need to tell the relative, sir, please, can you help us get a new cloth so that we can remove the one that is wet and put a one that is not wet so that the patient can feel warm. Any other question before I will do the GCS part of it? Please, you can indicate in the chat box. If there's any question, you can just put it in the chat box, or you can also unmute and ask the question. Okay, let me go through. Okay, so here I want to talk about the GCS that we talked about before. So first of all, let me start by saying what does GCS stand for? GCS is an abbreviation. GCS. It's an abbreviation of Glasgow Coma Scale. Hmm? So it's a scale that is used to know if patient is conscious, or if patient is semi-conscious, or if the patient is completely unconscious in coma. Hmm? We call that GCS. If you have been in the hospital, you see it used almost all the time. GCS, GCS, GCS. Let's check the patient GCS. Let's see if the patient is unconscious. Let's know the level of how deeply unconscious the patient is. Hmm? So Glasgow Coma Scale. So Glasgow Coma Scale uses just three things. Hmm? Uses three things, just three things. The first one is eye opening. Eye opening, what call a response to eye opening. And the second one is verbal response. We call this best verbal response. We call it best. Why do we call it best? We call it best because we want to know how best did the patient respond. How best did the patient respond? And the last one is also best motor response. Best. So when you are adding a verbal response or motor response, you add best to them. But eye opening, we don't add best to eye opening because it's eye opening. But best verbal response, best motor response. So eye opening, best verbal response, and best motor response. Those are the three criteria, three things we use for GCS. So they have a total number, the total number. If we add our eye opening and we add our best verbal response and we add our best motor response, the total number we can get is 15. So like me and you now, me that is teaching you and you people that is listening to me, if we check our GCS will be 15, 15 over 15 because we are fully conscious. But in people that are sick in the hospital, is critically sick, if you check their GCS, most of them, their GCS might be 10, some of them might be 12, some might be 14, but it won't be 15 because they are not fully conscious. But this GCS of total of 15 is divided, the eye opening has the total number that can come out from it. And for eye opening, the total number you can get, the maximum score you can get from eye opening is 4. So it's rated from 1, 2, 3, and 4. And for best verbal response, the total score that you can get from best verbal response is 5. So best verbal response is rated 1, 2, 3, 4, 5. And best motor response, the total score you can get from best motor response is 6. So it's rated 1, 2, 3, 4, 5, and 6. So let's start analyzing them one after the other. So after this class, maybe by tomorrow, if you are in the hospital, you will try to any patient you see that look like the patient is not fully conscious. Try to assess the patient GCS and probably report. You try to assess the patient GCS to know how deeply unconscious the patient is. So we're going to start. We'll first of all start with the higher mark. We first start to assess the highest point that we can get. If the patient doesn't meet that highest point, we'll now go to a lower one. So for eye opening, if you go into a patient who is in the ward and that patient is seriously sick, and when you enter the ward, you are looking at the patient eye is opening. The patient eye is open. You enter in and you are looking at the patient is lying on bed. If that patient eye is open and the patient is seeing you as you enter the ward, that person's eye opening is 4 automatically. It's 4. That's what we call spontaneously. So we enter into the ward, we are looking at our patient lying on bed, and that patient eye is open. We say that patient eye opening is 4. But let's say we go into the ward and we look at that patient. The patient eye is closed. The patient eye is closed. But when we call that patient, we call the patient name. Let's say the patient name is Paul. We call Mr. Paul, and that patient opens the eye. The eye opening is 3. Remember, we say 4 is if the patient eye is open. Without calling the patient's name, without doing anything, we enter into the ward, the patient eye is opening, is 4. But we go into the ward, the patient eye is not open, and we call the patient's name, Mr. Paul. The patient open his eye. That patient eye opening is 3. So, but we call the patient's name. Remember, we say we enter, the patient eye is not open, so it can never be 4. We call the patient's name, Mr. Paul. The patient did not open the eyes, so it can be 3. It cannot be 3. So we now try to put pain. We try to put pain, cause pain to the person. So if we put pain, how do we cause pain to the person? We usually use our knuckle. We use our knuckle and press hard on the chest, the midsection of the person's chest, the patient's chest. We press it hard with our knuckle, the knuckle of our right hand. We put a pressure on the mid chest, press it hard. So if we apply that pain and the patient open the eyes, we say the patient GCS is 2. Remember, 4 is eye is open without doing anything. 3 is we'll call the person name and the person open eye. 2 is we have to put pen before the person will open the eyes. What if we put pen and the person still did not open his eyes? So if we put pen and the person did not open eye, that is, there is no response at all. We said the eye opening is 1. Eye opening is 1. So what of best verbal response? Well, best verbal response is also straightforward. We go into the ward and we see our patient lying on bed, Mr. Paul. We call Mr. Paul. Mr. Paul, how are you? He said, I am fine. Mr. Paul, what is your name? He said, my name is Paul. So this person is having a conversation that is clear and understandable. So we said the person is oriented because we called his name, he answered. We asked him his name. He told us his name. You can go further and ask him, Mr. Paul, where are you? He said, I'm in the hospital. What else? So the person is fully conscious, the person is know where he is. So patient can communicate with us without any issue. So any patient that can have this good conversation, the patient that can have this good conversation, that person best verbal response is 5. Person best verbal response is 5. So what if we ask Mr. Paul, how are you? Mr. Paul probably say, I am fine. And we say, Mr. Paul, where are you at? Mr. Paul say, I am in the market, but Mr. Paul is in the hospital. So that person is confused. That person is confused. He's not oriented. He doesn't know where he is. So in such a conversation where the person is confused, he can still speak, but he's confused. That person's best verbal response is 4. What if we go in, we greet Mr. Paul, we say, Mr. Paul, how are you? And Mr. Paul just say a word. And Mr. Paul, where are you at? Mr. Paul, where are you at? Do you know where you are? Mr. Paul just said a word that is not related to what we are asking him. And Mr. Paul, what did you eat this morning? Mr. Paul say, we ask, the question is, Mr. Paul, what did you eat this morning? Mr. Paul say, market. You can see there is no relation between market and what Mr. Paul ate this morning. So that is what we regard as inappropriate word. So the person can still say a word, but carry a word that does not relate to what you are asking the person and say those words. So in that case, inappropriate use of words. So we say the person has a best verbal response of 3. What of inappropriate sound? We asked Mr. Paul, what did you eat this morning? Mr. Paul did. So that is just a sound, it's not a word. Mr. Paul, what is your name? It's a sound, it's not a word. So in such an inappropriate sound, incomprehensible sound, or inappropriate sound, the best verbal response for that person is 2. What if we call Mr. Paul, what is your name? No response, no sound, nothing. Best verbal response for in that case is just 1. Okay, what about best motor response? Best motor response again is just straightforward. Mr. Paul, raise your hand. Mr. Paul obeys command, raise the hand up. Mr. Paul, raise your leg. Mr. Paul, obey command and raise the leg up. So any person that can obey this command, that person's best motor response is 6. Straightforward. It is 6. Is 6. Best motor response is 6. So what if we tell Mr. Paul, raise your hand? Mr. Paul did not raise hand. Mr. Paul, raise your leg. Mr. Paul did not raise leg. So what we need to do at this point in time, well, we need to again put pressure. Use our knuckle, the knuckles of our right hand, and put pressure on the mid chest. So if we put that pressure on the mid chest, if Mr. Paul pull his hand towards your hand, that hand you are putting the pressure on, as if he's trying to pull your hand out. We say that Mr. Paul is localizing the pain. You know where the pain is coming from. I'm carrying my knuckle, the knuckle of my right hand. I'm pressing the chest of Mr. Paul. And Mr. Paul carry his right hand, grab my own hand, and try to pull it out. He's localizing it. He's localizing that this pain is in my chest. So any person that can localize pain, we say that person's best motor response is 5. What if I'm putting this pain, putting this pressure on Mr. Paul's chest, and instead of Mr. Paul bringing his hand to remove my own hand, Mr. Paul is pulling his hand away from where the pain is coming from. I'm using the knuckle of my right hand. I put deep pressure on Mr. Paul's chest, and instead of Mr. Paul trying to use his hand to pull my own hand out, Mr. Paul is pulling his hand away from where I am putting the pain. So when that happens, we say the person is withdrawing from pain. He's going away. He's sending his hand away from where the pain is coming from. So any patient that withdraws to pain, we say the person's best motor response is 4. What if we are putting the pain as we are putting the pressure? We put the pressure and the Mr. Paul just flex. At the hospital, you will know what flexion is. The person will just flex the leg or flex the hand. If the person flex the leg or flex the hand, we say the person's best motor response is 3. If we also still put in pressure and the person extend, in the hospital, you also know what an extension is. The person extend, Mr. Paul extend the hand and extend the leg. In that case, the best motor response is 2. But if we put all this pressure, we are putting pressure, causing Mr. Paul to feel pain, but there's no response. Mr. Paul did not respond, did not move the leg, did not move the hand, did not do anything. In that case, we still no response. In that case of no response, the person's best motor response is just 1. So look at it. The maximum we can get is 15. The minimum we can get is 3. So GCS can range between 3 to 15. Minimum of 3, a maximum of 15. Some people that have GCS of 3, we regard them that they are dead, because a dead person can move, the person can't open eye, the person can't talk, and the person can't move any part of the body. So that is GCS. So how do we calculate it? It's simple. We add the score we get in eye opening. Let's say we get a score of 2 in eye opening. We add it to the score of we get in best verbal response. Let's say we get 5. Or sorry, if we get 2 in eye opening, we get 4 in best verbal response. 2 plus 4 is 6. And in best motor response, let's say in best motor response, we get 4 again. So when I have 2, 4, 4, we add 2 plus 4, that is 6, plus another 4, that is 10. So what is that person's GCS? It's 10 over 15. Okay, now let's again, in eye opening we have 2. In eye opening we have 2. In best verbal response, we also have 2. That is 2 plus 2, 4. And in best motor response now, we now have 3. So we now have 2, 2, 3. 2 plus 2, 4. 4 plus 3, 7. So the GCS of that person is 7 over 15. What is this person? What does this person have? Remember, we said that any GCS that is less than 15 is coma. So this person is in coma. A GCS of 7 over 15. The person is in coma. So we need to call the ICU people. We admit the patient in ICU. We'll pass an endotracheal tube for the person, and we'll connect the person to machine. Machine will have to help the person in breathing. So that is how we assess GCS. So let's entertain questions. Okay, the calculation is not clear. Okay, the calculation is simple. The calculation is simple. We said we have to add the score. The score we get. We have to add the score we get in eye opening. That score we get in eye opening, we write it down. Okay, in eye opening, we get 2. We write 2 down. In best verbal response, we have 3. We write 3 down. In best motor response, we have 4. We write 4 down. So what we have? We have 3. Sorry, we have 2. Eye opening 2. We have 2 plus 3. 3 is best verbal response. So 2 plus 3 plus 4. That will be 2 plus 3, 5. 5 plus 4. That is 9. Total of 9. So we have 9 out of 15. So we'll now put 9 over 15. The person GCS is 9 over 15. Okay, let me this opening of 3. Of course, we say Mr. Paul is in the ward. We enter in the ward. We call Mr. Paul. When we enter, Mr. Paul's eyes was closed. Mr. Paul's eyes was not open. So we enter into the ward. Mr. Paul's eyes was closed. We call Mr. Paul, and Mr. Paul opened his eyes. Looking at us, I said, doctor, welcome. Person, I simply write 3 down. We write 3 down. As we write the 3 down, response. We call Mr. Paul. How are you? Mr. Paul say, I am fine. We now ask Mr. Paul, Mr. Paul, where are you at? Mr. Paul say, I am in the market. How will Mr. Paul be in the market while Mr. Paul is lying on the hospital bed at Health Specialist Hospital? He's in the hospital, but he's telling us that he's in the market. So he's confused. And Mr. Paul is confused. So what is the Mr. Paul best verbal response? It is 4 because he's confused. So we are now going to write 3 plus 4. 3 is eye-opening and 4 is Mr. Paul's best verbal response. So when I go to best motor response, we say, Mr. Paul, can you raise your hand? Mr. Paul did not obey command. He didn't do anything. Mr. Paul, raise your hand. He didn't do anything. Okay, Mr. Paul, raise your leg. Pain. Mr. Paul, bring his hand and grab our hand and remove it because you don't want to feel pain again. So what is Mr. Paul's best motor response? It is 5. It is 5. So we are going to write plus 5. So how do we calculate it? We have 3 for I. We have 4. So it will be 3 plus 4. We have 4 for best verbal response. 3 for eye opening. 4 for best verbal response. So we now have plus 5. We have 5 for best motor response. 3 for eye opening. 4 for best verbal response. And 5 for best motor response. So total, what do we have? 3 plus 4 plus 5. So 3 plus 4 is 7. 7 plus 5 is 12. So what is Mr. Paul GCS? Simple. 12 over 15. So that's how we calculate GCS. So more questions. More questions. Guys, you can indicate, you can unmute yourself, ask question, or you can type in the chat box. You can type in the chat box, or you can unmute yourself and ask question. If everything is clear, if there is no question, just no question, so that we know that that's the class. These guys respond. I'm waiting for you. If you can't hear me as well, please tell me that you can't hear me. You can put in the chat box that you can't hear me. If you can hear me, also say yes, we can hear you, please. Okay, so if you can hear me, just type that you can hear me so that if there's no question, we'll end the class. All right. Okay, so we'll end the class now. Some of the guys that have left probably